they end up having to pick between their wife and their mom, and
allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
So I will call this regular Moffett County Board of County Commissioners meeting to order on Tuesday, August 27th, 2024 at 8:30 a.m. And I will note that Commissioner Booyer is on the road, so he will not be able to join us today. And as Vice Chair, I will be leading the meeting. So I would make a motion as Chair to approve the agenda as presented this morning.
Second.
Okay, I have a motion and second. All in favor? Aye. And I would also make a motion on the consent agenda this morning, items A through H, striking I and J and accepting K.
Second.
Okay, I have a motion and a second with those changes. All in favor? Aye, motion carries. Okay. So I will now open it up for public comment. If anyone has anything they would like to share or talk to the board about. Someone wants to come and tell us how great and wonderful Craig is, or nothing? Nothing from Maybell? All right. Any general discussion? We'll roll right along. Road and Bridge Department, Dan Miller, bid recommendations for, start with road striping.
Good morning.
Good morning.
So every year we do striping down on the hazmat routes. And just we had to do some of County Road 4 that we chip seal. Anyway, we advertised for 50 miles of painting. County Road 4 just gets center stripe. The hazmats get fog lines also. Anyway, we got two bids. One from Stripes a Lot in Montrose for $96,893.25. And then out of St. George, Utah, straight stripe painting was $140,640.08. So we would recommend that the bid be awarded to Stripe a Lot Inc. They've done it the last few years and do a good job, so.
Last year we had to cut some out on that. Are we kind of back to our normal, or are we still
Yeah,
kind of
we're-
cutting some out?
We're in good shape right now.
We do.
Stripe a Lot hits it every time, don't they?
Just about, yeah.
With the cheaper.
And they're familiar with the route, so that's helpful too.
Yeah.
Okay, I'll make a motion to go with the recommended bid with Stripe a Lot Inc. for $96,893.25.
Okay, I'll second. A motion and second. Any discussion? Hearing none. All in favor? Aye. Motion carries. And the shop truck?
Okay, we need a new shop truck. Our old one is a 2006 model. It retired. We put it out for bid. And we only got one response. That was from Victory Motors Craig. The cabin chassis that we want is $67,800. They're gonna give us $8,000 per trade-in. And then they're gonna take it to Denver to retrofit the box that we have and the crane and everything. That's $12,000. And then we can get additional leaf springs to support the crane for a total of $74,700. Our budget was $130,000. We were gonna get a whole truck. We decided to do some retrofitting and save some money here, so we recommend we take the bid from Victory Motors.
Always good when we can come in under budget. Any other questions?
Retrofitting is just because it came off a Ford going on a Dodge.
It'll fit.
Chassis are different. So
It'll fit though.
makes sense. I'll make a motion to go with Victory Motors on this new 2024 Ram 5500 cabin chassis. Retrofitting. A total of $74,700.
Second. Any further discussion? Hearing none, all in favor?
Aye.
Aye, motion carries.
Thank you.
And all right, Department of Human Services, Kristen Grajeda and Rachel Bauer with HR.
Good morning. On behalf of Human Resources and Human Services Department, we are here to request salary increases for all DHS staff and the addition of another child welfare supervisor position and part-time self-sufficiency case manager. Over the last 5 years, Moffett County has struggled to fill and retain positions. DHS staff are faced with extreme burnout, high-stress situations, and secondary trauma. Child welfare specifically experiences working late nights, weekends, on-call rotation, and high workloads. The county is mandated by Title 26 to run and operate DHS services with or without staff. Therefore, making it critical that you please consider and approve the following pay structure and staffing changes below. So we have Exhibit A, which would be for all Department of Human Services positions. In Exhibit A, you'll see that each position is going up about 1 grade. So it has the current grade with the max step at 6, which we budget for at the max step 6, and then the proposed grade for each position there. And then Exhibit B, effective September 1st, 2024 of this year. We would like to propose increasing the wages for all the child welfare staff, including adding the addition of a child welfare manager. The total cost to the county with wages, retirement, and fringe, total cost would be $47,122.69 for that. And we do believe that that will help us to be able to attract applicants to those positions that we haven't been able to fill over the last 5 years. It's been on and off. We did just post our caseworker positions and lead caseworker position. We ran it for 2 weeks. We have no applicants right now. So I do believe that that will help attract some applicants there. And then Exhibit C, those proposed changes would be effective January 1st of 2025 for the remaining positions. And that overall cost to the county would be $72,907.83, that the county portion would be responsible for that. Justification for proposed changes. Unlike most county departments, DHS is generally reimbursed 80% through the state and also through federal allocations. Of the 8 major funding allocations, DHS was underspent in 5 of those allocations. Moffett County is considered a balance of state county, meaning that at the end of the state fiscal year, unspent allocations are applied to other balance of other state counties that have overspent. It is uncommon that a balance of state county has to pay additional funds at the end of the fiscal year. DHS has the availability to move funds to cover over expenditures and maximize funding sources and allocations that are typically underspent. Overall, it's estimated to be less than 5% increase to the overall 2025 budget expenditures. And that would be based off of the cost to the county 2025 budget fiscal year, the $72,907. One thing that I want to note too is just, over the last couple of months talking to staff just that have either came and left and stuff, they definitely love what they do and stuff. And I think that pay could be a great incentive to try to keep people too. But all in all, they all have the common goal. They're here to help the families and the children that they work with too. So, did you want to add anything?
No, I think that's
Okay.
great. Thank you for covering all that.
Taking notes. We appreciate the time in the workshops too, to kind of go through this and bring the state in to share some of how the state allocations are done and some of the reimbursements, and get an idea too from the state on how we can kind of maximize how we're utilizing the program dollars and utilizing the people that are working for us within those program dollars. I think that was helpful
Mhm.
conversation, and while their funding structure is complex and kind of a pain, I believe, it's helpful to see how we can use that, and that it's not just the county making those decisions and those payments. So I appreciate you bringing them in and sharing that with us.
Yeah, just to help with her, it was very educational. There's just a lot of it that I didn't realize, with the different pots you had and not utilizing some of them, you know, as much as those other counties did that went over. That was pretty amazing to me. But anyway, good job.
Definitely.
Especially playing by their rules that seem to change all the time. Just when you get the state figured out, you're like, wait, when did you send that memo to change everything?
The only thing that stays the same is change.
Right?
Yeah.
Sure.
And the fact that they don't do anything that's simple. Right?
No.
Ready?
Mhm.
I'll go ahead and make a motion to approve the salary changes and staff changes for DHS. So for the estimated additional costs to the county for the remainder of the 2024 fiscal year, $47,122.69. And then the estimated additional cost for the 2025 fiscal year, $72,907.83.
I will second that. And the only comment that I would make is, we do have a budget process for doing this, but I think the reason for having this discussion and making a decision today on that is we do have some qualified upper level staff that has applied and has interviewed, and we can't make decisions without having some decisions already made. So
I appreciate that.
with that discussion, any other discussion?
Just hope we can find a place to stay.
Right, we're gonna put bunk beds in that 20,000 square foot we have left in the back.
There you go.
Right? So I have a motion and a second. All in favor? Aye.
Thank you.
Yeah, thank you.
All right. And now we will have a presentation from Memorial Regional Health, Jennifer Riley and Paula Belcher. Thank you. Good morning.
Good morning. We need to turn these on or?
Nope.
You don't need them.
You should
Okay.
be good.
So I don't know if you know Paula Belcher. She's our Director of Population Health.
Right.
And I don't have anything more to say. Don't need to belabor it. Thank you so much for letting us take the time to talk with you today to share some information about one of the hospital's programs. I'm here to talk about the Hospital Transformation Program. And we will move on to, I wanted to clarify. Population health. A lot of people have a question about the difference between public health and population health, and I thought it would be a good opportunity to just explain that. Public health, we're looking at a lot of infectious diseases, community benefit, and it's primarily taxpayer funded. When we look at population health, we're looking at more chronic disease management. We're looking at prevention and management of diseases that are more chronic based, and it's primarily going to be funded through private enterprise, hospitals, clinics, not taxpayer dollars. So that's kind of when you hear the phrase population health, that would be the distinction between the two, public and population. You go to the next slide. Thank you. So the Hospital Transformation Program is a program initiated through the Department of Healthcare Policy and Finance, HCPF. And HCPF oversees Health First Colorado, which is the program that oversees Medicaid benefits. It is required for all hospitals in the state of Colorado that have received Medicaid reimbursement. So it's a pretty big deal, and all of the hospitals are impacted by it, urban and rural. And the goal is I don't know if you've heard the phrase transition from pay for service for pay for performance. So instead of getting paid for every 3 doctor's visits, they want to say, okay, instead of 3 visits, can we address the issue with 1 by being more effective in the care that we're provided? So it's a whole concept through the entire country, Medicare and Medicaid, that we're paying for performance, not just for the services of care. We're also, the program outlines key activities and performance measures. So there was a big list of measures that all the hospitals could choose from. And each hospital had the chance to say, okay, these are the initiatives that we want to address. And so what it did is give a lot of flexibility to the hospitals to say, okay, we want to focus on these issues, and an urban hospital might have some different focus areas, or rural hospitals have some different things we want to work on. So it was great that they gave hospitals those options, but it also makes it really hard to standardize how that's going to be measured. So as you can imagine, urban hospitals have more resources than rural. If we pick that same measure, but we're measured to that same standard, who has the advantage? And so, the intent is good, but it's going to be challenging when they're looking at the performance metrics of how the hospitals do. And the reason that's really important is because of the financial impacts. Next slide, please. So the overarching goals are to improve patient health outcomes, and that would be with the physical health, mental health, and behavioral health, and lower the overall cost of care. And that's looking at both the cost to the patient and cost to the healthcare system. And what they want to do is reduce avoidable hospital admissions. And that's where, a patient comes in, their issue isn't really primarily addressed. They might be sent home too soon, and they come back either to the ED or the hospital. That is not good patient care, and that increases the cost to both the patient and to the healthcare system, to Medicaid. And then increase our efficiency and effectiveness. Do we have the right policies and procedures in place to treat the conditions that we're seeing? And so it's really raising the hospitals to a higher standard, making sure that they have the right protocols for treating whatever conditions that the patients come in with. We want to improve collaboration among hospitals, community health partners, social service agencies, and other healthcare providers. And so think about that from the standpoint of us working with Northwest Colorado Health. We may have a patient that comes into our emergency department, but they see one of their primary care providers. So how do we make sure that that provider knows their patient was in the ED, and so that they can follow up them appropriately? Another thing, working with the social service agencies, with DHS, with Love Inc., with Community Budget Center, a lot of those organizations, you don't think of them as healthcare providers, but we really do need to work closely with them because of the patient population. It's not just the medical needs, it's life, it's the environment that people live in, their work situation. So all of the more closely we can work with our community agencies and the healthcare providers, the more wraparound support the patients are going to get. And I will say, we really, if you look at our community, we have an amazing group of social service agencies, DHS, and then those private agencies that communicate really well. They know the patients that they're working with, the community members that they're working with, and they work really, really well together. And we are very fortunate to have that network. Lastly, again, just talking about that transition to value-based care, we're trying to pay for performance, that we provide the better care with fewer visits. Next slide. So when we're looking at the priority areas, behavioral health and substance use disorder is one of the things that we see a lot, especially coming into the ED, and then the implication of those ED visits to potential admissions. How do we get those people into the treatment that they need? Outreach and engagement for core populations. So high needs patients, we're looking at medical, like if somebody has uncontrolled diabetes, what do we do about that? It's a high risk or a high need illness. At-risk patients, we're looking at a lot of people that have trauma, whether that's family trauma as a childhood that carries into the adulthood. What do we do to help those core populations? And a lot of times we see those things come present in collaboration, high risk and high needs. Social needs that impact health, and we'll talk a little bit in greater detail later, but we're looking at transportation, housing, employment, financial strain. A lot of the times that comes down to either difficulty paying for utilities or difficulty paying for medical bills. As we all know, medical expenses are out of control. And then lastly, the creation of clinical and operational efficiencies. I'll give you a quick example of that. We had a program where we had to verify eligibility. We had to do enrollment. We had to do enrollment paperwork. We had to do intake paperwork. Then we had the appointment, and then we had to report all the data back to the funder. It was a grant funded program. And so internally, we were, we had a core group running the grant, but then we were, reaching out to all these different departments, and it was confusing. It was frustrating. It was inefficient. So we went through a planning cycle and we're like, okay, well, what if we took parts of this back so we weren't, zigzagging to other groups. And we went from probably, I would say, about a 10-step process to a 3-step process. It was much more efficient for the staff involved, and it was much more clear to the patients that were involved. What were the expectations? What did they need to do, and what could they expect? So constantly looking at this from the standpoint of how do we be more efficient? How do we reduce the burden on the staff? And how do we make it a better experience for the patients? Next slide. So again, just circling back, all hospitals in the state of Colorado are required to participate in this if they want to receive Medicaid payments. So there are 86 hospitals participating. There are 9 health systems comprising 56 hospitals. That's like your UC Health, your Intermountain Health, et cetera. And then there are 28 independent hospitals, including MRH. We are not part of a system. There are 42 rural hospitals and 42 urban hospitals. And I did the math on that. I know that adds up to 84. It's because 2 of those are specialty clinics that aren't rural or urban. They're just one-offs. The way the measures were kind of doled out. If you were a large hospital, you had to select 10 measures. Medium-sized hospitals did 8 measures, and small hospitals, critical access hospitals like us, and then specialty hospitals were required to select 6 measures. Of the 32 critical access hospitals, 18 are independent and 14 are part of a health system. As you know, we are independent. We are a county-owned hospital. Next slide, please. So looking at the Medicaid population in Moffat County, the reason this is significant is kind of how it's changed over time. I pulled this slide about a year ago, and so that's why it doesn't go up through 2023. But if you look at Moffat County census, we have about a population of 13,292. And our Medicaid population back in 2013 was only about 11%. It was inching up until COVID, and then COVID hit. And in 2020, because of that expansion of Medicaid, it jumped up to 21%. And then by the end of 2022, we were at 34% of our county has Medicaid. As of this year, 2023, and this data comes from HCPF, 36% of Moffat County is on Medicaid. So that's a large portion that needs that benefit, and that we are providing care for those patients and other patients in the community. I think this slide is also interesting, just showing the changes over time where the other insurance providers have pretty much stayed steady, but Medicaid has gone up and private insurance through employers has come down. And so that's another thing that we're, kind of reckoning it with, and we're thinking about what is that impact with the future of Craig, with mine closures and the power plant. So there is the potential that our Medicaid population will increase even further. Next slide. So looking at the population we treat, looking at 2023, 18% of our inpatient volume, and that's going to be patients that were admitted for hospital care, had Medicaid, and 34% of our ED volume had Medicaid also. And so that kind of tracks with the percentage of Medicaid insured patients in the county. Of those patients, looking specifically at emergency department statistics, 7% of those visitors had 4 or more visits, and that's what we call high utilizers. And the concern there is if you're coming to the ED for your primary care, That's an expensive solution. We really want to get those patients established with a primary care physician. So they're getting preventative care that is a lot less expensive and much more proactive. So that's a concern when we see a lot of high utilizers. I looked at the data and one person had 14 visits. I believe that person, it wasn't necessarily medically based. A lot of it is social isolation. It was his way of having human connection. That's not a healthy way of having human connection. So a lot of it, I think it's important to note, it's not always medical care. A lot of it is that behavioral health and the mental health. And so what can we do to support that as well? 17% of those visits were related to alcoholism, mental health, substance use, and I do want to note that the mental health was also a lot of suicide attempts or just ideation, thinking about it, and how do we address that so it doesn't become an attempt. Next slide, please. So just really quick to understand the eligibility for Medicaid. It is, you have to be in Colorado, a resident of Colorado, a US citizen, national permanent resident or legal alien. It's largely based on household size and income. And so you can see, think of a family of 4, a parent and 2 kids. The maximum income is really, really low. And so it is a lot of people that are in some, I think it's fair to say, a state of poverty. Other eligibility requirements may be if they're pregnant, responsible for a child that is 18 or younger, blind or have another disability, or that 65 and older population. Did you want to add anything further? I thought, okay. So next slide, please. I want to put this in context. It's not just the numbers of like, I'm a family of 1 and I make X amount of money. And these are examples of patients we have and community members that we have supported in our community. So a lot of times we think of Medicaid as insurance for poor people or unemployed people. And I think that's not necessarily an accurate, there's much more to it. We have helped a single mom who supported 2 children on 1 salary. That was a situation where the dad was absent. He had a substance use disorder. He was not paying child support. And she was working really hard to support those 2 kids on the 1 salary. We had you see this all the time with hospitality workers working multiple jobs. None of those employers can provide benefits. It's not feasible. So individuals are working multiple jobs and still not getting benefits despite working really hard. And it's not the business owners who don't want to provide that benefit. It's just they can't afford it either. We had a gentleman who was diagnosed with cancer. He was working full time. I think he was in his late 50s. Just didn't have enough money saved up, and he had to stop working because of his cancer treatment. And fortunately, because of the Affordable Care Act, you know, pre-existing conditions don't prevent people from having insurance, but he was able to get Medicaid because he couldn't work, and so he was able to receive the treatment he needed. And then again, the family of 4, 1 parent working full time, the other parent was a full-time caregiver, and they had 1 child wheelchair bound. Physical and cognitive disabilities going to children's at least monthly. And it's a huge strain on their family, but they're doing the best they can for their child. But if they didn't have the Medicaid, that child wouldn't receive the care that he needed. So Medicaid benefits individuals, families, and communities by ensuring healthcare is accessible and affordable to people who could otherwise not afford it. So I really do want to emphasize trying to remove some of that stigma about Medicaid. These are very often hardworking people that are just struggling. Mm-hmm. So next slide, please. So the potential impact of HCP. So it ensures Medicaid reimbursement of at-risk dollars, and I'll talk about that in a minute. And you know, the goal is to support a healthier community and our population. If we don't do this well, we lose money. There are these at-risk, and I call it, for lack of a better description, a bonus payment. You get paid a little bit more if you do this well, but it'll nick you if you don't meet the metrics and do this work well. Our mission at MRH is to improve the quality of life for the communities we serve through patient-centered healthcare and service excellence. So at the end of the day, That is our goal. If we don't do this well, we fail. And so I strongly believe we will do this well. We will meet our mission. And we will also ensure that we get those at-risk payments. Next slide, please. So in terms of those at-risk dollars, it is pay for performance, like we were talking about earlier. What they're looking at for the metrics is a 5% increase year over year, that you've done better by 5%. And if you do that, you get these bonus payments. Now, the money is spread out across those 86 hospitals. And so if like one hospital does better, you get a little bit more money. And if another hospital does poorly, you don't. But if everybody does well, they're dividing the pot. So there's not necessarily like a huge perk. It's just, you're not going to be financially hurt by it. So the upside risk is, if you do really well, you can get more money that another hospital is not going to get because they didn't perform as well. The unearned at-risk dollars are pooled together and then they're redistributed based on the performance measures. I want to make sure I mention. Okay, next slide, please. There is no additional money for this. And when we think about like, did they rebudget? They didn't. They did not get any more money for this program. It's based on hospital provider fees. So it's no new or additional money. It's just a redistribution of funding that's already kind of in that pot. So the money comes from inpatient base rate supplemental payments, outpatient supplemental payments, and then uncompensated care supplemental patients. Jennifer, this is more your world than mine. Do you have anything to add on that?
Yeah, the hospital provider fee, you might remember it changed to a fee a few years ago because it was to take that out of the state's general fund budget. And that's a fee that's assessed against all hospitals based on various factors, your inpatient rate, your outpatient, for Medicaid patients, your outpatient Medicaid percentage, and then your uncompensated care percentage. So we get charged a fee, we pay that to the state, and then the state draws down federal dollars to match, there's different calculations, different percentages. Then that goes back into it's called the Chase fee, and I can't remember what the acronym stands for. And then that gets pushed back out to hospitals based on those same factors. So we pay a little, for us in particular, we pay a smaller portion than we get back. So we have a net positive impact on the provider fee, and every hospital pays a fee and gets money redistributed back to them. It's very confusing. And there's a lot going on at the state level talking about this fee, and that's a whole separate meeting that we can talk about that, but yeah.
All right.
It's convoluted.
Thank you.
Yeah.
Next slide, please. So this is where we're going to start talking about the measures themselves. And so the 6 measures the areas where we're going to focus on are 30-day all-cause risk-adjusted hospital readmission, follow-up appointments with a clinician made prior to discharge, a follow-up visit with a primary care physician following an emergency department visit, social needs screening and notification, a collaborative discharge plan for patients with a diagnosis of a mental illness or substance use disorder. And that's for the ED or inpatient setting, and then increasing the number of annual wellness visits within a 12-month period. Next slide, please. Okay, so 30-day all-cause readmission. So the reason that's phrased that way is, let's say someone is admitted for uncontrolled diabetes, and within 30 days they come back for congestive heart failure. If they came back just for the diabetes, that's one measure. But for us, it's like, if you come back for any reason, this could potentially count against us. And it's also that 30 days is really key. If they come back on the 31st day, we're in the clear. If they come back on day 30, we get dinged for that. And so the goal here is, if a patient is admitted, what do we do to make sure that they get the follow-up care they need with a primary care physician so that their condition is better managed and they don't have to come back to the hospital? Because if you've ever been admitted to the hospital, we provide wonderful care, but that's not where most people want to be. So what we have done here is try to increase the communication between the hospital side with our discharge planners and then my team, the care coordination team. And so what we're implementing is, if a patient has been admitted to the hospital, within a rolling 12-month period, my team automatically gets a notification. And then we're going to work with their provider to outreach to that patient, make sure they get an appointment, make sure they come in for their appointment, figure out what's going on and try and better address the core reason for their admission and anything else that might be going on. So that is something, a workflow that we have put in place to follow up these patients to help reduce that possibility for readmission. This is kind of, we're looking at the patient at the top, then the hospitalists, those are the doctors, and the discharge planners are kind of that next tier. And then it comes down to, do we need to make sure they see a primary care physician, a specialist? Again, a lot of that heart disease, make sure they get in with a cardiologist, and then the care coordination team that can make sure that they have transportation, that they, if they went home hungry, we can get them some food, whatever that the case may be. Next slide, please. So follow-up appointment scheduled prior to an inpatient discharge. And so this is another thing we find that if you don't get that appointment scheduled before they leave, do I really need to see the doctor? And the answer is yes, you do. So the goal here is to make sure they, if I'm getting discharged on a Wednesday, I'm going to see a doctor within a week, within a month, whatever the case may be, but they leave the hospital with an appointment. And so that they know that, time, date, and who they're going to see as a follow-up. The challenge we're facing here is patients discharged on the weekends, clinics are closed. And so, how do you get that appointment scheduled before they leave? So what we're trying to do is make sure if we have any indication that a patient is going to discharge on the weekend, we get that appointment scheduled on Friday for sometime the following week. Just because they don't need to not be in the building to schedule that appointment. We want to be very proactive and make sure that when they exit the building, they know what their next steps are. And the next step should include seeing a doctor. Next slide, please. Follow-up appointment following an emergency department visit. Similar concept, except we're not necessarily scheduling the appointment before they leave. But if you're being seen in the ED, if it's something other than I cut my finger and I need stitches, if it's anything kind of more serious than that, you probably should see a doctor and nip that in the bud. Find out what's going on, what is the root cause, and what do you need to do to address it. So if the patient doesn't have an identified primary care physician, PCP, we're going to try and connect them with one of our providers, if they're interested, or a provider in the community, and UC Health, Northwest Colorado Health. We have a list of providers. It's patient choice. We're not going to say you have to see our doctors. We certainly want them to. We think they should, but it's all about patient choice, and we want to make sure that you can choose where you go. Just make sure you go see somebody. And then educate patients regarding what their coverage is, so that they know that they don't have to worry about, it's going to be expensive. No, your insurance actually pays for this. So let's make sure we get you in. So there's an education component with this too, to make sure that, they're not going to avoid their visit because of the concerns of the cost. I just noticed something in the corner. No, you can keep going. I had put it in the little corner, and you can see this on the slides later. It says either self-reported data or claims data. I do want to make a note that there are 3 of the measures that it's just HCBUF knows if it happened or it didn't, because they get billed for it. So it's a claims-based data. We don't have to do any additional reporting. There are 3 measures that are self-reported, and this is one of them: social needs screening. And so we are doing the documentation to say, yeah, we did ask these questions about are they having challenges with these issues, and we did the screening. The answer was yes or no. And if there was a yes, we followed up on it. And so this is one of the self-reported measures. So social determinants of health, I don't know if you've heard that phrase, talking about environmental conditions that affect people and their healthcare. Where are you born? We know statistically people who live in rural areas have a shorter lifespan. They die sooner than people in urban areas, partly because of healthcare. We don't have as much access to healthcare. So where were you born? Where do you live? Work and play. We have some professions here that are hazardous to people's lives. But in the city, they have greater pollution. So, they may have more respiratory issues. So where you live plays a part in this. And then, age, how do people age? So there's a lot of stuff that affects your quality of life. Some of the things that we're looking for are housing instability. We know housing is super expensive, and people oftentimes, I'm thinking of the gentleman with cancer who couldn't work. So if he can't pay for his rent, he's going to be evicted. So now he not only has to deal with cancer, he's homeless. We actually had that situation. And so the housing instability is a huge concern. Food insecurity, we hear it a lot. Parents make sure that their kids eat before they do. And so that's great for the kid, but it's not right for the parents to go hungry either. Transportation, can people get to their appointments? We live in a small town, yeah, sure, you can walk in the summer, but in winter, is anybody going to walk up that hill in a snowstorm? The ability to pay utilities, can you keep the light on? Can you keep the heat on? We had a gentleman who had carbon monoxide poisoning because he had a propane heater in his our trailer, and he was making himself ill because there was not sufficient ventilation. And so he kept coming back to the hospital, and it took us a while to figure out it was carbon monoxide poisoning, because who would think that you're accidentally poisoning yourself? And then personal safety, that's we're looking at domestic violence and safety issues. So those are the things we're screening for. And if any of those pop up as a positive, my team once again gets a referral, and we reach out and see what we can do to help. Next slide. So as you can imagine, behavioral health and substance use disorder, it's a concern nationwide, and we are not exempt from that. And so a lot of what we see in the emergency department are people that are struggling with overdoses, suicide attempts, suicidal ideation. And so instead of kind of triaging them then and there and sending them home with a safety plan, what else might we need to do? Do we need to get them into treatment? Can we set up an appointment for them to see a mental health provider next week? Do we need to get them down to a substance treatment facility, or to Mind Springs for some inpatient mental health support? So instead of just, I don't want to say patting them on the head and sending them on their way, what can we more proactively do to have those needs addressed? And so in the last year, through some funding through this program, we have hired a social worker in our emergency department, and we're trying to make that a more robust response then and there, that people with these specific issues are receiving more immediate support, and not saying, hey, somebody will follow up with you next week. I don't need help next week. I need help right now. And so it's just a more intentional response to people with these specific diagnoses. One more slide. A few more slides. Okay, so this is the last measure. We are looking at, on the clinic side, this is more of a clinic measure rather than a hospital measure, trying to get people in for wellness visits, just their annual exam. Because what we do know is people that have routine care, they're healthier. And because you're again, nipping things in the bud, if you can diagnose pre-diabetes early, and get them on, maybe a better nutrition plan, meet with a dietitian, get them on some medications, so it doesn't become full-blown diabetes, you're going to have a better health outcome down the road. So just trying to get people in for their wellness visits, and that's adult and children. Those well visits for kids are really important too. Ultimately, we do know that prevention can reduce those ED visits, and then we're improving care, and we're reducing costs. And so, and again, this aligns with measure 3, the ED follow-up. So we have our patient access team. We have a list based on birth month, because it was the easiest way to do this. We're calling people in their birth month saying, hey, can we get you in for an appointment to see your PCP? And if they don't, we know if they don't have a primary care physician, so we can say, hey, can we help you establish care with a provider? If they want to see one of our doctors, great. Again, if they don't, that's fine. It's patient choice. They can see another provider in the community. We just want to make sure that they get in for a primary care visit. Next slide, please. Okay, so other considerations. We know that just because we can identify a variety of needs doesn't mean we always have the resources to address the needs. I think housing is a great example of that. We have a lot of people that come and are asking for housing assistance. And if it is a true state of homelessness, we know putting them up in a hotel is not sustainable. And we also know it's really not fair to the hotel vendors. We also know most of the proprietors won't accept people with a local address, because there are other concerns. So our solution, unfortunately, is to say, we can help you get to Grand Junction. to the shelter there. We can help you get to Denver for the shelters there. But locally, we do not have a housing resource. And that's really hard, especially when people have roots here. People love living here. But when something has happened with their housing situation where they're living out of their car, we've had people we know are living in storage units. It's not safe. It's not a way a person should live, but we don't have a great solution. So that's one of probably, I think, the hardest things that we face for people coming to us. A lot of the other things, like we can help you with food. There are really a lot of food resources here. With transportation, you've probably seen those MedRide cars. Fabulous resource. Not only do they do a great job getting people places, but their customer service is amazing, which is really nice to hear. So we have a lot of resources, but where we lack, we lack in a big way. So we're working on that. The other thing I think is really important is choice. We can offer assistance and people can choose to accept it or decline it. And we face that a lot where like, this is what we can offer you. And people decline because it's not the solution they want, and that's okay. But we can't force them, but we also can't, we don't want to band-aid the solution. We're looking for sustainable solutions. So for instance, if we offer a housing solution, like your best resource is to the shelter in Grand Junction that has healthcare, it has food, it can help you find a job. But if that's not what you want, that is your choice. But I can't put you up in a hotel because that is not a financially sustainable solution for anyone. And it's not a solution. So, we may follow up with people with a plan and they don't follow up on their plan. Like, this is what we're going to do. They're not ready to do that. And that's okay. And hopefully they know that we're a resource when they're ready to make a change in their life. They'll remember us and they'll come back and we'll see what we can do. So yeah, just like, it's choice. We can offer assistance. People can choose to accept it or decline it. Next slide. So patient engagement, how can we better engage with patients in being proactive in their healthcare decisions and outcomes? And I think a lot of that is education. And so part of it, I didn't really touch on it today, but we're going to be doing a lot more with patient education regarding that follow-up, senior provider, what does your insurance cover, et cetera. And then community engagement. And that's part of the reason we're here today. Like, this is what's going on. This is one of the things we're facing. Are there opportunities for us to better work with county government, city government, with the DHS department, who I will say is a great partner to us? The health partnership, they have a monthly care collaborative meeting where the groups come together. We talk about what we're seeing, how we can leverage, resources together. United Way has their quarterly HRC meeting. So again, the groups coming together, like saying, this is what we're seeing in the community. And so what can we do to work together? And then, sharing information. This is what we're doing. If you need help with X, let's talk about this. And so a really great network of resources, but where can we do better? And part of it is like, what do you need to know about the work we're doing? And where can we ask you for help, to make this program successful? And I believe that is my last slide. Do you have questions about any of that? That was a lot.
No.
Okay. If something comes to mind later, please reach out. I'm happy to, talk one-on-one. Good. It's a lot of work. And I think, you feel accomplished when you know that you've helped somebody, stay out of the ED, like you help them get into treatment. But you're also seeing a lot of people that are not ready for that. And you just hope for the best, that they'll come back when they're ready to make a change.
And is this our seventh year?
This is our 6th year. So it'll be 7 in January.
So we've been developing this for 6 years. Paula has been at the helm the whole time. And I think now we are really firing on all cylinders, but our biggest challenge is getting people engaged in the community as well as the participants. Doesn't change the fact that if we don't meet the metrics, we don't receive those bonus payments, but we're still going to work hard. That's our mission, to improve the quality of life. So, and it's a big component of our payer mix.
Thank you so much for your
Thank
time
you.
and
Yeah,
letting
really
me
appreciate
share
it.
this.
Yeah, thank you.
Well, that does it for our agenda. So our next regular scheduled BOCC meeting will be Tuesday, September 10th, right here at 8:30 a.m. And we are adjourned at 9:20.
Thanks, everybody.
Thank you.
Jennifer, meet here.
It'll be, yeah, Ryan and Dana Levac. Yeah, and probably Brittany. I'm leading a manager thing, so I won't be here, but if you can send me the invite Monday at 10.
Brian sent me an email.
Right.
So I'll follow up with him and we'll
Perfect.
just do that at 10 here before
Great.
the
Thank you.
roadshow. Yep, thank you. How much are they?
$20.